The following lecture is aimed for dental students, interns, junior trainees, junior residents of oral surgery and oral maxillofacial surgery, as well as junior residents of other dental specialties. I also dedicate this lecture to my fellow colleagues and dental practitioners of several dental specialties all over the world. May you all benefit from it. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. Please allow me to give a brief bio about the speaker. My name is Mohammed Al-Shulkami. I'm a professor of oral and maxillofacial surgery at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. This lovely city, which lies around 120 kilometers to the eastern of the capital Cairo in Egypt. It was named after the late great ruler of Egypt, Khedive Ismail, the one who did the opening ceremonies of the Suez Canal in 1869. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. The main topic for today, I find it one of the most important topics in the dental practice, is the management of the medically compromised patients. And our topic for this lecture, which I consider one of the most important topics in the medically compromised patients management, is the management of cardiovascular disorders in the dental practice. Actually, cardiovascular disorders are one of the most serious disorders that you can face in dental practice. In 2017, the cardiovascular disorders accounted for 46% of mortality rates in Egypt. In 2018, around 30 million patients were diagnosed having cardiovascular disorders in the US. And actually, worldwide, the number of cardiovascular disease patients has doubled from roughly 271 million patients in 1990 to around 523 million in 2019. So please take it seriously. What are we going to talk about today? We have 8 diseases we are going to discuss. First of all, angina pectoris, then myocardial infarction, and then the coronary artery bypass graft and angioplasty, congestive heart failure, cardiac arrhythmias or cardiac dysrhythmias, cerebrovascular accident, and hypertension, and last but not the least, the endocarditis risk patients. So let's have a brief overview of the pathophysiology of most of these diseases interrelated together. The main key player is hypertension, of course combined with other factors as we are going to discuss later. If it is untreated or deteriorated, it will lead to angina pectoris. If the angina pectoris left untreated or deteriorate, it will lead to myocardial infarction. Furthermore, myocardial infarction, if it affects the cardiac muscle grossly or affects one of the conducting systems in the heart, it will lead to cardiac arrhythmias or cardiac dysrhythmias and congestive heart failure. And on an attempt to correct the position or to correct the condition while the patient having angina or myocardial infarction, angioplasty and coronary artery bypass grafts, CABG, are introduced to try to stop the deterioration and correct the condition. On the other hand, hypertension is one of the leading factors which might lead to cerebrovascular accident and brain hemorrhage. And also, if the cerebrovascular accident is has been caused by ischemic reasons, angioplasty can be done to correct this condition. So let's start with angina pectoris. What do you have today? We are going to discuss the pathophysiology, types of angina, signs and symptoms, treatment, predisposing factors, potential risks, and last but not the least, the management protocol to get the dental treatment in a safe fashion. Let's start with the pathophysiology. The coronary arteries are branching from the aorta. We have the right coronary artery and the left coronary artery, which branches to the most important left anterior descending artery and the circumflex artery. As we said before, hypertension leads to arteriosclerotic changes and thickening in the lining of the arteries, along with several factors we are going to discuss later, increased cholesterol and fats and obesity and diabetes. It leads finally to partial occlusion of the blood vessel with what we call plaque deposit. And finally, this plaque changes the architecture of the artery and it loses its elasticity, so the blood supply coming from this area or coming to the area supplied by the artery is insufficient. And when the blood supply is insufficient, this might be a predisposing factor for chest pain. Another variation for angina is what we call the coronary artery spasm. The artery is normal and is not narrowed by plaque deposits, but it can be caused by only coronary artery spasm. And finally, we face the dilemma when we have decreased blood flow and combined with increased demand or increased oxygen consumption, as the patient is trying to do some physical activity or some sort of emotional stress. So here we face the dilemma that the blood supply will not be able to cope with the high oxygen consumption, and here we have the anginic attack. What are the types of angina? The first type and the most common type, the classic or the stable angina, it is precipitated by emotional or physical stress, or physical exertion. The duration lies between 1 minute to 15 minutes, and it responds very well to nitroglycerin. The second type is the variant angina, which is precipitated by coronary artery spasm. The duration is variable, and also it responds very well to nitroglycerin. Last but not the least, the final type is the unstable or crescendo angina. Unfortunately, this is the most dangerous type of angina. Now, we don't recommend that dental practice should be given to such a case. There is no precipitating factor. Any factor, or even the patient can have this attack triggered while he's at rest. Duration may last up to 30 minutes, and the response to nitroglycerin is questionable. What are the predisposing factors that are underlying to cause angina? The genetic factor plays a role, of course. Atherosclerosis, or as we said, arteriosclerotic changes, hyperthyroidism, and anemia, all combined with other factors. Definitely smoking, high blood pressure, diabetes mellitus, obesity. Moreover, lack of physical activity and laziness, consumption of unhealthy and junk food, over stress and over anxiety, and last but not the least, excessive nervousness. So please be aware of your lifestyle and what you do to yourself. The condition is diagnosed by CT on the coronary arteries. You do CT coronaries to see the section and the thickening of the plaque or narrowing of the arteries. Furthermore, echocardiography and electrocardiogram or ECG can be performed. What are the signs and symptoms of a typical anginic attack? Substernal pain on the left side of the chest, projecting to the left shoulder, left arm, and even it might radiate to the jaw and the neck. And you might have some cases coming complaining of jaw and or temporomandibular joint pain, and finally it is related to angina pain. And I think several articles have described this relationship. I think a Colombian article I have read or I have heard of was describing such a relation. Coming to the pain description, it's according to the patient's words. You might have squeezing pain, excruciating pain, stabbing pain, sharp, bursting and shooting pain, according to how everyone describes this pain. However, the bottom line, it is a very acute and sharp and unbearable, terrible pain. Another important sign is the Levine sign, which is where the patient clenches his fist in front of the chest when he has the attack. And if you find your patient on the dental chair clenches his fist like that, you should suspect, of course, anginic attack. What are the treatment drugs used to deal with angina? First of all, we have the long-acting nitrates. Example of them is the Izordil. However, long-acting nitrates are vasodilators, and so they might have some side effects like headache and postural hypotension and flushing of skin and face. Secondly, we have the beta blockers like Inderal and Viscan, and they have also some side effects like asthma development, and they might cause severe bradycardia. Last but not the least, the nitroglycerin or sublingual nitroglycerin tablets like Nitrostat, Nitrol or Dinitra, and as common vasodilators they have the same side effects, headache and postural hypotension. They can cause postural hypotension when the patient changes his posture suddenly. And coming to understand the effect of the nitrates or the sublingual nitroglycerin in particular in relieving the attack, it is a potent vasodilator, and as we see from the figure, it leads to the widening of the lumen of the blood vessels. It is a potent coronary vasodilator. So if we can imagine that the coronary vasodilatation is the only cause for relieving the anginic attack, we might be wrong, or we might only have half of the truth. Actually, the sublingual nitroglycerin, when we put it sublingually, and why we choose to put it sublingually, because it's the fastest route to reach the bloodstream. The area is highly vascular and it's fastly absorbed. So it goes to the peripheral blood vessels and leads to peripheral vasodilatation. And this peripheral vasodilatation, in addition to the coronary vasodilatation, the peripheral vasodilatation will lead to decrease of the venous return going back to the heart. And decreasing the venous return will decrease further the burden on the heart and the amount of blood the heart has to pump. And when the heart starts to pump its cardiac output, it is going to pump it against a less peripheral resistance according to the peripheral vasodilatation which was caused by the nitrates. So this is how it carries out its job to relieve the angina attack within few minutes. But it's not only through coronary vasodilatation, because we have another drug which is a very potent vasodilator like epinephrine. So why don't we use epinephrine to relieve the anginic attack? Epinephrine is a very potent coronary vasodilator through the beta receptors. However, epinephrine has other effects on the cardiovascular system, as we are going to see. Epinephrine acts on the myocardium through beta receptors, causing what we call the positive inotropic effect, which is increase in the muscular contractility or the contracting force of the muscles, which increases the cardiac output. Furthermore, it leads to what we call the positive chronotropic effect, which increases the heart rate. So it increases both the force of contractility of the muscle and the heart rate. Moreover, the effect on overall cardiovascular dynamics is increase in the systolic and diastolic blood pressure, cardiac output and the stroke volume, and the heart rate, myocardial contractility, and of course it increases the oxygen consumption. So epinephrine, apparently it might lead to coronary vasodilatation, but it increases the oxygen consumption by far, so that whenever whatever the increase in the vasodilatation of the coronary blood vessels in the angina patient will not be able to cope or catch up with the oxygen consumption and the heart rate and the cardiac output which the epinephrine led to. So that's why the American Heart Association has limited the use of epinephrine in the cardiovascular patients. What are the precipitating factors for angina attack to occur? We should know this quite well and try to avoid such conditions during our dental appointment. Physical activity or physical exertion, and this of course should not happen on the dental chair. Hot, humid environment. You should be sure that we have a good AC working in the waiting area and in the dental office to avoid the patient feels overheating. Or on the other hand, the cold weather also, or if the patient feels cold, this might lead to anginic attack. And of course the operators are working under stress and wearing face masks, face shields and head caps and gowns and whatever, so they feel a little bit hot than usual. So they set the AC to a colder setting to feel comfortable while they are working. The patient might sometimes complain from feeling cold, so it's either to direct the fan of the AC away from the patient or cover the patient with a blanket of some sort of cover to let him feel a little bit warm. Also large meals, you should advise your patient to have his breakfast and have his meal and schedule him in the morning appointment according to the stress reduction protocol, but advise him not to have large meals. Emotional stress, of course, may be bad news, or sometimes also good news may lead to emotional stress of the patient, and sometimes the argument, anxiety in meetings or whatsoever. So please don't argue with your patient unless you are talking about the fees, and of course the fees should be agreed upon and arranged before the dental surgery setting. Caffeine ingestion and also fever and anemia and thyrotoxicosis. And in these conditions, I think in an anemic patient or thyrotoxic uncontrolled patient, or in patient when he's feverish, you might not be able, of course, to arrange a dental setting. Cigarette smoking, of course, is among the causes of angina as well, of cardiovascular disorders, and it might provoke an anginic attack. Last but not the least, the smog, polluted environment, and high altitudes. So, coming to the potential risks of anginic patients, what risks can we face? Stress and anxiety during the dental setting might lead to anginic attack. And if we are unfortunate that day, deterioration of the anginic attack might lead to myocardial infarction and finally cardiac arrest. So let's outline the management protocol. First of all, physical evaluation and medical consultation about the condition. And as we said, there are some cases of angina, like the unstable angina, which are not scheduled for outpatient dental practice whatsoever. They should be hospitalized, and the medical consultation is mandatory in such cases. Stress reduction protocol should be implemented. Particularly the anesthesia and pain control should be accentuated, profound, and of a good duration. And here comes the famous question about using anesthesia with epinephrine or without epinephrine. Actually, using plain anesthesia will give us a less profound and a less duration anesthesia, and if you cannot control the pain while doing a stressful surgery to the patient, this might lead to provocation of an anginic attack. So please, we should use epinephrine, but we should respect the American Heart Association guidelines, limiting the dose of the epinephrine not to be more than 0.04 milligram per half an hour visit. Sublingual nitroglycerin tablets should be readily available in our emergency kit, or we can have also the patient get his sublingual nitroglycerin tablets, because the dose is metered for the patient. Chair position is usually supine or semi-supine, and please avoid, under any circumstances or any condition, avoid the what we call the syncope position or the Trendelenburg position, which is legs up and head down. If you put the patient in this position, you are going to increase the venous return coming back to the heart, and you are going to increase the load on the heart, and this provokes an anginic attack and increases the pain, and the patient feels that he cannot breathe well. Last but not the least, oxygen supplementation should be available. We can use oxygen supplementation to increase the oxygenation of the cardiac muscle with good ventilation, and if we resort to nitrous oxide for sedation or alleviate the anxiety of the patient, this might be good as well. So let's translate what we said about the American Heart Association. We said that the American Heart Association has limited the amount of the epinephrine during a half-an-hour visit for the cardiovascular patient to 0.04 milligram of epinephrine. So let's translate this to number of carpools, of dental carpools. How many carpools can we use for such a patient? So we need to know what does it mean to have 1 to 100,000 of epinephrine in our dental carpool. It means that we have 1 gram for every 100,000 milliliter of the solution. And as expressing the dosage in milligram or microgram, so we need to change the gram to milligrams, multiplying by 1,000. So it means that we have 1,000 milligram per every 100,000 milliliter. And so let's divide by 1,000 and remove the 3 zeros from the numerator and the denominator. We are going to have 1 milligram per 100 milliliter, which means 0.01 milligram per milliliter. And how many milliliters do we have in our carpool? We have 1.8 milliliter in the dental carpool. So please multiply 0.01 milligram by 1.8. It will give us 0.080 milligram per 1 carpool. Or if we express it in micrograms, we are going to multiply by 1,000. So we'll have 10 microgram per milliliter or 80 microgram per 1 carpool. And coming back to the American Heart Association guideline, we said that it is 0.04 milligram. Dividing 0.04 milligram of 0.018 is going to give us 2 and a fraction. So we can use 2 carpools safely within a half-an-hour visit for the patient with anginic attack or cardiovascular disease if the concentration is 1 to 100,000. But what if the concentration of the epinephrine is 1 to 50,000? This means it contains the double the amount of epinephrine, so we can use only 1 carpool in the dental visit. However, when we have 1 to 200,000 of epinephrine, which means that we have half the amount of the carpool containing 1 to 100,000, so we can use up to 4 carpools during the dental visit. Let's now go to myocardial infarction and talk about the pathophysiology, signs and symptoms, and treatment and management. The pathophysiology of the myocardial infarction, it starts as an anginic attack, and furthermore there is deterioration and there is complete occlusion in the coronary vessels by a blood. So when the lumen is totally blocked, there is going to be infarction in the cardiac muscle. We have here anterior infarct. Furthermore, the infarction of the cardiac muscle might lead to congestive heart failure, and in case it affects the conducting system or the Purkinje fibers or the SA or the AV nodes, it's going to lead to failure of the conduction and cardiac arrhythmias as well. However, this might be reversed by doing a coronary artery bypass graft and stopping the deterioration of the condition. Regarding the signs and symptoms of the myocardial infarction, they are typically the same pain and the same distribution of pain like the anginic attack. However, it is more severe, and it is not unfortunately relieved by the sublingual nitroglycerin tablets. It's only relieved by morphine sulfate injection. And on the other hand, Acute cases should be treated by streptokinase, trying to dissolve the blood clots, and afterwards, as we said, it can be treated by coronary artery bypass graft to correct the condition. Coming to the management protocol, it is more or less the same as the angina, but with some differences. First of all, the physical evaluation and medical consultation to understand the patient's status and his condition and his eligibility or fitness for the minor oral surgery on an outpatient basis or not. Then we can apply the stress reduction protocol, including good accentuated and profound anesthesia with good duration, and now we have being confident of using epinephrine, but of course according to the guidelines of the American Heart Association. Here we have to defer the treatment for 6 months following the first myocardial infarction attack. And actually this recommendation has been based on statistical evidence that the liability or the possibility for having another attack is very high within the first 6 months after the first attack. And after 6 months had elapsed, you have this possibility to minimum. So please follow this guideline. Unless you have emergency, you can resort to the medical consultation, and you can put the patient in a hospital setting and have him under control if any attack should happen. And of course, in the outpatient basis, we can have morphine sulfate injection in the drugs of the emergency kit. And the chair position, as we said before, it should be in supine or semi-supine position, and always avoid, under any circumstances, if the patient loses consciousness or whatsoever, avoid the Trendelenburg's position, or the what we call the supine position, which is the head down, legs up, to avoid increasing the venous return and the load over the heart. The myocardial infarction patients are put on anticoagulant therapy to prevent any thromboembolic events in the future. So here we need to check the clotting profile, and please refer to the lecture of the hematological disorders and the anticoagulant therapy for further details. And we should here order the clotting profile, the PT and INR, to get a good understanding of the patient's status. Is he eligible, or is the patient eligible for the dental surgery or not? Last but not the least, the oxygen supplementation. As we said, it should be present. Oxygen supplementation could be given to the patient and would be of good benefit with good ventilation. And if we use the nitrous oxide for sedation, this can be arranged beforehand. And after what we said, we can realize that angina and myocardial infarction are mostly the same, and actually they are like the two sides of a coin, of one coin. Coming to angioplasty and coronary artery bypass graft, or CABG, we are going to talk about the nature, potential problems of such patients, and of course the management protocol. Angioplasty, balloon angioplasty, is used. It's a procedure where you introduce a catheter from the femoral artery and you bypass it through the vasculature until reaching the heart of the aorta and entering the coronary artery. You introduce a small balloon, a deflated balloon, on the tip of the catheter, and of course you can follow the passage of the wire and the catheter through a screen, a radiographic screen, and using an angiogram or giving contrast media to have the blood vessels evident and apparent in the screen. And accordingly, the operators in the OR should be wearing a lead apron weighing around 11 kilograms. It's a very hectic procedure. The technical name for such a procedure is called percutaneous transluminal coronary angioplasty, PTCA, or percutaneous coronary intervention. On reaching the coronary vessels, the narrowed coronary vessels with plaque lining the blood vessel, when the balloon is inflated, it actually compresses the blockage or the fatty plaque against the artery walls, and it increases the diameter of the blood vessel and lead to widening, and of course afterwards increasing the blood flow to the heart. But however, unfortunately, this procedure is sometimes complicated by vessel recoil and restenosis afterwards. And so to overcome the problem of restenosis once more, balloon angioplasty with stenting have been introduced. The same idea, getting through the femoral artery and going to the angina or the narrow blood vessels of the coronary artery, and then you introduce the metallic mesh tube, which acts as a scaffold to provide support to the coronary artery. It is introduced on the tip of the catheter, and then you inflate the balloon. It expands the size of the artery and hold it open. Then the balloon is deflated and withdrawn, and leaving the stent in place. And finally, after several weeks, the artery endothelium is going to heal around the stent. And this had been found to avoid the restenosis, and the recoil and the restenosis of the blood vessel is kept to a minimum. Coming to the CABG, the coronary artery bypass graft, sometimes when the cardiologist try to perform the angioplasty or the balloon catheter or the stenting or whatsoever, they find that the artery has a degree of damage which is past remedy or past angioplasty. It is ragged, it is has lost its elasticity. They cannot pass the catheter through the artery. If they try to expand, they might have some rupture or explosion of the artery. So they resort to the coronary artery bypass graft, which is taking a blood vessel from the same human being and do a bypass from the arch of the aorta and beyond the blockage caused by the blood clot. The internal thoracic arteries, also called ITA grafts or the internal mammary artery, are the most common bypass graft used, especially in the isolated cases or in a single bypass surgery. However, when there is more than one bypass graft is needed, most surgeons use a saphenous vein from the leg. And this is the heart-lung machine used to control the operation and the pumping of the heart during the cardiothoracic open heart surgery. An article published in the Journal of American Dental Association titled Coronary Artery Stents Review and Patient Management Recommendations. It has been published in June 2000. It has been concluded that after stent placement, patients usually maintained or antiplatelet regimens or anticoagulants, and this may necessitate choosing medication that do not potentiate their effects. So be aware of the drug interactions. And some sort of controversy or discussion have been raised for antibiotic prophylaxis of patients with stents, and it has been found that it is largely missing or not conclusive from the previous literature. However, there has been some indication of antibiotic prophylaxis, and it is said to be required only within the first few weeks after the stent placement. Another title, Coronary Stents, the dental hygienist's role in treating patients with special needs. So, when treating such patients who undergone coronary angioplasty or stenting, we should be aware of the answers of two questions. The date of the stent placement, and is the patient currently on antiplatelet or anticoagulant therapy or not. And accordingly, this will direct our management protocol. First of all, management of angioplasty cases. We can consult the physician, and regarding the antibiotic prophylaxis, as we said before, it is recommended to give an antibiotic prophylaxis most probably for the 3 to 6 months after the surgery have been done, and after that there is no need for antibiotic prophylaxis. And if we decide to give prophylaxis, we use ampicillin or amoxicillin 2 grams, or otherwise if the patient is allergic to penicillin, 600 milligram of clindamycin, and this should be given 1 hour before the procedure or our dental procedure or our dental surgery. On the other hand, the antiplatelet therapy used or the anticoagulant therapy used, we should know that the type of the drug the patient is using as an anticoagulant. If it is antiplatelet, we can use the bleeding time to monitor it, or if it is an antithrombin, we can use the PT on the INR. And please refer for further details to the hematological disorders lecture. And last but not the least, we should be aware of drug interactions with anticoagulants. Of course, non-steroidal anti-inflammatory drugs, penicillin, tetracyclines, and metronidazole, they can interact with anticoagulants. So keep the patient safe and stay away from such drugs. On the other hand, the CABG patient, there is no need for antibiotic prophylaxis before any dental surgery. 3 to 6 months should elapse after the CABG surgery, and should you need any intervention or dental surgery before or during this period, you should resort to the medical professional and consult him. And if the patient's condition is stable and under control, you can go to the outpatient surgery basis during this period. However, such patients are under anticoagulant therapy, and you should perform clotting profile to get good understanding of the patient's status before having any dental surgery, or if you are going to stop the drug or not, and you can consult the physician regarding this problem. So always bear in mind that the CABG patient is a previous myocardial infarction or angina patient, and so follow the same protocol followed for the angina or the myocardial infarction during their dental treatment. Congestive heart failure. We are going to discuss the pathophysiology, signs and symptoms, potential problems, and last but not the least, the management protocol. In order for congestive heart failure or hypertrophic cardiomyopathy to occur, we have one of two situations. First of all, the diseased myocardium versus normal workload, where the myocardial infarction or diseased muscle or the dying muscle cannot cope or deal with normal workload, or either we have a normal myocardium versus work overload. And in all instances, there is always increase in the end diastolic volume. And according to Starling's law, when we have a muscle stretched, it should react and return by increased force of contraction. And whenever the ventricles are filled with excessive amount of blood, it reacts by excessive force of contraction and increasing the force of contraction to be able to expel all the blood out to the peripheral blood vessels. However, a limit when it is exceeded, or until such a limit where there is exceeding of the capability of the muscle to catch up with the increased end diastolic volume, and here there is what we call the congestive heart failure happens and occurs, and there is congestion of the blood everywhere and leading to interstitial fluid accumulation and pulmonary edema, and according to the signs and symptoms that we are going to discuss later. The patient with congestive heart failure suffers from orthopnea, which means shortness of the breath, and this is according to the accumulation of the blood coming back to the heart from the pulmonary vessels, and the accumulation of the blood leads to what we call pulmonary edema, and this leads to in turn to orthopnea. And another very important symptom is paroxysmal nocturnal dyspnea, and last but not the least, pedal edema. So the increase in the hydrostatic pressure of the blood vessels according to the accumulation of the blood and congestion and inability for the heart to pump it properly, there is always osmotic pressure and diffusion of the fluid in interstitial spaces of the legs and ankle and extremities. So we have what we call the pitting edema. If you put your finger on this swelling, it's going to you see indentation in the foot, and this denotes pedal edema. When the patient lies down and start to sleep, after a couple of hours of sleeping, there is pooling of the blood and redistribution of the pooled blood there is reabsorption of the fluids from the leg, and it goes back to the heart and to the lungs, and the heart will not be able to cope with it, and so there's accumulation of the amount of blood in the lungs and increasing the lung edema, and this leads to what we call the paroxysmal nocturnal dyspnea. The patient wakes up feeling air hunger, it's trying to open windows or trying to have trying to breathe normally. He feels that he cannot breathe. So this is according to the redistribution of the fluids while the patient is sleeping, and we advise such patients to put their upper half of the body on several pillows to avoid such a problem. What are the potential problems that we could face? A cardiac arrest could develop, and the patient have bleeding tendency because such patients are put on anticoagulants. A cerebrovascular accident could develop. The patient, as we said, suffers from dyspnea or shortness of breath. They should be put in a comfortable chair position. And last but not the least, they take diuretics to decrease the blood volume, and this might lead to a hypotension, postural hypotension. The physician should be consulted. Stress reduction protocol should be implemented, and if the case is not under control, we can arrange the dental procedure in a hospital setting. Chair position should be always upright to avoid orthopnea, and we should check the clotting profile to understand the patient status, and is the INR or PT let him eligible for dental surgery or not. As we said, last but not the least, the diuretics used might lead that the patient need to go to the restroom frequently, and we should advise the patient to go to the restroom before the dental procedure, and of course, as we said before, limit our the time of our dental visit, and be aware of the hypotension. The postural hypotension could occur, as we said, even in the angina and myocardial infarction patient using the vasodilators. So please, in such patients, or in general in the cardiovascular patients, don't change the position of the patient suddenly. If you put the patient in a supine position, for example, then put the patient in the upright or the zero position and let him rest for a couple of minutes there, because if he stands up suddenly, he might have a hypotensive attack or postural hypotensive attack, and he can faint or fall on the ground. So to avoid his injury, we should change the position of the patient on the chair, or going from the dental chair to standing up gradually, please. Albert Einstein once said, "Strive not to be a success, but rather to be of value." I would like to thank you for your kind attention.